next speaker to thank you. You're sharing your slides already, so I appreciate that. Dr. John Kern is a good friend to primary care. He is a clinical professor of psychiatry at the University of Washington. He works in the AIM Center, supporting the translation of evidence-based approaches to behavioral health integration. Prior to this, he worked for 27 years in the public sector as a mental health center CMO and founded an FQHC to help address the medical needs of his psychiatric clientele, and served as CMO of that FQHC for 2 years. He still works as a consultant psychiatrist in the collaborative care model in a Seattle FQHC. Dr. Kern, the floor is yours. Thank you for joining us.
Very good. Thank you, Marhaf. Thrilled to be here. Thrilled to see the big crowd. Sorry we can't be all together. So I will just jump right in. Let's see here. Here we go. No training without its learning objectives. Today, at the end of this activity, I'm hoping that you will be able to describe aspects of a collaborative care model team, explain the advantages of the primary care setting, not widely known, for the provision of mental health services, and to be in a position to work effectively with a psychiatric consultant to provide care to most people with behavioral health disorders, not that you don't already, as we'll talk about. So a little bit, I had forgotten how much of this I had put in my my intro from Marhaf, but just to give a little sense of where I come from and what I know about primary care. I was a community mental health center doc for 27 years before coming to UW. I worked in beautiful Northwest Indiana. For those of you familiar with Chicago, it's sort of the industrial area, the non-fashionable industrial area of Chicago. I'm interested in improving the model of care provided in those agencies. I'm interested in collaborative care. I've been doing that for about 14 years. That's behavioral health and primary care. I'm interested in also in the medical care of people living with serious mental illness. It's also called by these other names. And I've been working with that population, which was my kind of first kind of integration for 15 years. And I did open and serve as a CMO of a federally qualified health center. As a psychiatrist, it was very challenging, I will say that, and I got a real eyeful of what's involved and what's needed and what's asked of folks who work in them. And I've become interested in, through much of this time, in the scope of expanding the scope of collaborative care. Traditionally, it's just, as we'll see, thought of as a treatment for depression and anxiety, but every other damn thing walks in your door. And so it gets turned to those ends, but the research hasn't kept up. And so I've been interested in the care of bipolar disorder. I've been interested in, I'm working right now with a Medicare Advantage organization, figuring out how to take care of everybody that comes in a primary care setting. So that's kind of what I'm thinking about all day long. Mental health in the US. Mental health conditions are very common. 26.2% per year suffer from a diagnosable psychiatric disorder, let alone distress of other kinds. It's very poorly resourced. About 12% of people who have a psychiatric disorder see a psychiatrist even one time in a year. And if you've ever had a bad depression, you know that probably doesn't cut it. And that's just for those 12%. The future is not good for traditional psychiatric care in the traditional model. Psychiatrists are reducing in number to some degree. The residencies have just started going up a little bit. These numbers from 2003 to 13 actually did reflect a reduction. But it's, as you may know, it takes a long time to spin up a new residency. And so because we're old, the average age of US psychiatrists is almost 60. I'm slightly older than the average. Many new psychiatrists work part-time. One of the reasons that folks will take up psychiatry is its reputation for being flexible in terms of lifestyle, and it is. And often young psychiatrists with families will take advantage of this, which they should. But this just means that the kind of gross number of hours available is not very great. And then many psychiatrists have divorced themselves from the insurance reimbursement system altogether and really work for cash only, which really which really limits access for people who depend on insurance and who aren't made out of money. But you knew this already. In most settings, refer to psych is just not a realistic plan. It just doesn't, like, there is no there. You all provide most mental health care. 79% of antidepressant medicines are prescribed by primary care providers, and about 60% of the people being treated for depression in the United States are seen by primary care providers. Unfortunately, that doesn't work very well for reasons that I'm going to clarify, reasons that are addressable, so that it can be better. The best studied means of improving psychiatric access is collaborative care. What it refers to, collaborative care, is not a generic term for doing, cooperating and being agreeable. It has to do with a very specific model of using information and a team-based approach, and the use of a psychiatric consultant to improve the care and provide treatment basically at arm's length. So there's usually an in-house behavioral health care manager, which is not so unusual. There's a psychiatric caseload consultant, so that's somebody like me who's sitting usually somewhere else, providing consultation by way of information provided to me by the team of the primary care provider and the behavioral health consultant. And then there's the use of data. It's very important to efficiently direct care. So if you have limited psychiatric resources, you don't want to spread it. You don't want to spread it thinly over every single person you see. You want to provide care in a rational way to those people who need their care adjusted or changed or directed. And then there's the use of evidence-based treatments in preference to others, preference to just whatever seems like a good idea. The secret sauce of this is a couple of things. What really makes it go, this not only is this best studied, it's been head over heels the most effective. It's got, and the reason that it is because of measurement-based care. Basically, I'm sure all of you are familiar with the depression rating scales and using those to direct care, and the aspect of the psychiatric caseload review, which I just described. It turns out there's research pretty solid research to suggest that those may be the things that really make it go. And so driving or planning or implementing mental health and primary care going forward needs to include those things. Okay, we were going to do a Zoom poll here. I'm hoping that we were able to set that up, Simone.
Yes, we're all good to go.
Awesome. So is that on me? Who makes it? Oh, polling. Here we go. Boom. Polling. Okay, here we go. How many of you do some form of team-based care now? Pick one of these things. If you do in-house behavioral health provider, consultant psychiatrist, somebody giving you advice or something fancier that I would like to hear about, and let me know whether it works for you. So we'll just take a minute for this. Simone, are you getting the responses?
Yes, I can share them whenever we're ready. I see 43 out of 78 folks have voted.
Okay, usually try to get 60, so 70%. Yeah, maybe by the time we get to 50 or so.
Yeah, we're at about 55%.
Okay, let's do it. Okay, so everybody's no, I didn't give an option for nothing. I probably should have done that. 61% said pretty well, but could use some improvement. Isn't that always the way? But that's good. It's good to hear that this is happening, and that you all have some context for what we're talking about. So thanks for sharing that. Okie doke. Okay. So traditionally, the collaborative care model, which is, as you probably know, a product of the University of Washington, has been thought of as a way of addressing relatively straightforward, mild to moderate mental illness. But of course, every other thing walks in your front door, as I said before. And it turns out that in the last 20 years, there's been quite an array of studies expanding the scope of collaborative care. I actually get a Google Scholar email once a week with all the new articles with collaborative care in the name that are published, and it's just a fire hose. It's just getting more and more and all over the world. And these kinds of things have gotten to be fairly well described as responsive to a collaborative care setting. So this is you can see the list yourself. I don't have to read it to you, but these are you know, there's getting to be more what's called the deep end of the pool, the stuff that's harder to treat, the stuff that's more complex, the stuff that ordinarily you would think this is a refer to psych kind of case. Among these studies is something hot off the presses, which is a SPIRIT study. The SPIRIT study was done at UW. Sadly, I was not involved my own personal self. I came along at the wrong time, but I would have loved to for reasons that I will share in a minute. What they did is they studied in rural federally qualified health centers in Washington, Michigan, and Arkansas the treatment of bipolar and PTSD in those settings using a collaborative care model. And what they did is they had a collaborative care arm where there was an in-house care manager and then on the phone consultant and the psychiatric consultants working in a rural FQHC, and they compared that to a more traditional model, albeit tele, where the patient got direct service from a university-based, either UW or University of Michigan psychologist or psychiatrist. And it was a tough crowd. They were poor and they were sick. Something like 88% had a perceived need for mental health services. 2/3 were unemployed. The average amount of the rating for mental health related quality of life was more than 2 standard deviations below the mean normally found in these settings. What they found is that the collaborative care arm was as effective as direct psychiatric care and evidence-based psychotherapy, and they were both very effective, as effective as in any other documented treatment of bipolar illness. And it was very well received by providers and patients. There's always this concern that this kind of weird distance model with the psychiatric consultant not being really visible will feel too odd, but that was not the experience at all of the primary care providers who were actually doing the prescribing with advice and consult from the psychiatric consultant. And so that will be published probably in July. I think it takes forever, but this is extremely encouraging. It's very exciting for me because this is the care of folks with particular bipolar disorder in primary care has long been an interest in mine. And back in my old shop in Indiana, I had a series of 920 patients with bipolar disorder that we treated in an FQ. And I think we demonstrated pretty clearly that could be done. Now, I'm going to talk about something that nobody else talks about, which is why primary care is a better place to provide mental health care than a psychiatric clinic. I feel qualified to speak about this. I was, for 22 years, the CMO of a mental health center, a large, comprehensive mental health center. And I was also for 15 years or something like that, the psychiatric consultant in FQ, and I ran an FQ. So I have some sense of what it's like to do on both sides. And in my view, primary care, with the exception of patients who need wraparound services, people with very severe mental illness who need housing and case management and the like, with the exception of those patients, primary care is, in my view, a better place to provide mental health care. And it's a cultural difference. In primary care, you can actually get an appointment when you aren't feeling well and need one. So if you develop a cough and fever and shortness of breath and chest pain and you lose your sense of taste, you can probably talk to somebody. Similarly, if you develop, if your depression starts to give way or your hypomania is starting to cycle up, you can actually get seen. If this happens and you're seen in a traditional mental health setting, in most places, including in my old shop, which I thought was pretty good shop, it turned out you can't get an appointment. You can get to see those of you who have been through this know that, it's, if you're trying to get hold of the psychiatrist in something less than 3 weeks, good luck. So that's no way to run a railroad. That's no way to take care of patients. And sadly, most psychiatric settings are set up more for the convenience of the practitioner than for the convenience of the patient. And so that's why it's better, if you're a patient, to be on the primary care side. Scheduled monitoring happens on schedule. So if you're treating someone with lithium, you're treating somebody with antipsychotic, and they need lipids, and they need lithium levels, and they need TSH, and they need whatever else they need, it just gets done. It's no big deal. On the mental health side, it's a big deal. You got to get an order. You got to find a lab. You got to get the result back. It's 10 times more difficult, and it tends not to happen, which is not good. For example, one of the things that was found in the largest study of antipsychotic treatment ever done, and this was a multi-center university study, is that 88% of the patients who were on antipsychotics were not getting the appropriate monitoring for dyslipidemia. In other words, they hadn't had a lipid profile done. 88%, and this was in a university setting. So that just gives you some sense of how good a job we do. Most people would rather be seen at the primary care clinic. So the reason I saw a series of 920 patients with bipolar disorder in a primary care setting is they would not go. So I would say, I run this other organization. I hired the psychiatrist. We will do your intake. We will do the financial. We will do everything in our power to smooth out all the barriers to this referral, to this agency that we actually know that's a mile and a half away. And about 20% of our referrals, year in and year out, were effective, 20%. And the reason is stigma. Stigma is better than it was. People go on TV. Famous people talk about their bipolar disorder. It's better, but it's not dead. And the kind of modal situation is that people will say, I don't want my truck in that parking lot. And so they won't go. So it just doesn't happen. And so a failed referral is almost the modal situation. So let's say you decide, yes, we need to do this in primary care. And you don't have as much psychiatric expertise as you would like. You'd like to have somebody down the hall. You'd like to have somebody immediately available. Or failing that, somebody you could reliably refer to and get information moved back and forth and get an evaluation in a reasonable period of time. That's hard. And so if you have a relatively limited amount of psychiatric expertise available, so for example, in my work with, I work with ICHS in Seattle, and I'm available to them about, I have quite a lot actually, about 8 hours a week. In my old shop, I had 4 to 6 hours a week for a whole clinic system. And you will need a psychiatric consultant. Remote works just great. Remote is fine. Remote is awesome. I'm a big fan of remote. And what's more, that's where they are. So the good news is that what you have access to does work. The big thing here, I believe, is that you can take what is inside the psychiatrist's head in terms of the knowledge of the disorders, the knowledge of how to proceed with evaluation, the kind of questions and data points you need to ask, the kind of history points you need to get, the kind of steps you take in terms of the standard measurement and prescription and following of people's progress and treatment. A lot of these things can be made into procedures, and primary care organizations are good at procedures. If you're used to taking care of people with chronic illnesses, and it's very much the same. Somebody comes in with diabetes, you make sure certain things happen. Somebody comes with asthma, you make sure certain things asthma. Somebody comes in on an antipsychotic, it could be the same. Somebody comes in with a bipolar illness, could be the same. It makes a big difference to do these kind of systematic things well, and that's often where mental health systems, even when you have enough psychiatrists, tend to drop the ball. And so taking advantage of your expertise in managing chronic disease actually is super helpful. So that this is, it turns out that a lot of what the psychiatrist does can be turned into a procedure. So what am I talking about? What do I mean by that? So I thought of some examples. For example, standard rate, and a lot of folks do this, right? I think this is pretty much a standard arrangement in primary care. Standard rating scales of the PHQ, certainly, and sometimes other things like the G87 and the audit, and in the shop where I used to work, the FQ where I used to work, everybody got that once a year, and everybody with a mood disorder diagnosis every visit, just like you would, you get your blood pressure done if you got blood pressure problem, et cetera, et cetera. Labs were checked by procedure for commonly used drugs. If you're in lithium, there's a protocol that has been so long, you get it. It's similar with antipsychotics. This is often where things go amiss. And what you do is you make as many things as you can into a procedure in that way. So here are some more examples. For example, the folks come in and they have a fairly clear-cut major depression, or they have an anxiety disorder, and it's fairly clear that what they need is a trial of an SSRI. It's pretty straightforward. There's a when I talk with folks about this, there's often questions about what meds should we use and how should we do it. What matters, in my view, is not the choice of medication, but the use of timely and very persistent follow-up. That's where people go awry. You can't give somebody really the wrong SSRI, but where primary care mental health goes awry is the very regimented, regular, frequent follow-up and modification of treatment. That's where the difference is between effective and non-effective treatment of, for example, depression with medication. And so that's, this is on the one hand, that's bad news. On the other hand, it's good news, because you can do that. You can, if you have that in mind, you can fix that. You can put those procedures in places. And this is one of the things that the presence of a collaborative care team does. That's one of the differences between primary care as usual and collaborative care. So this is an example of a flow chart. There's nothing special here. It's just a very, this is just the top part. It's not the whole flow chart. It's just a very, straightforward. There shouldn't be any surprises here. Somebody's depressed, then you make sure they don't have bipolar disorder, and if they're super anxious, then you make their trial low, you make their dose low, and if they get really agitated or bent out of shape, then you stop and talk to the consultant. It's not hard to do, and so the usual 95% of the time place where it goes awry is just getting everything done on time and getting the follow-up done on time, and just walking through the steps. Another example is bipolar illness. I already talked about the SPIRIT study. There's a vast VA SPIRIT experience with doing bipolar illness in primary care, and there was my study, which I published a couple years ago, and 920 folks seen entirely in an FQ, and entirely via remote consultation. I didn't see a single one of those people in person, though I weighed in on every single diagnosis and every single treatment change, every single one. And that was one of the rules. One of the rules is that it wouldn't be done unless I weighed in on it. This is an example of a roadmap that I wrote for that program. And the idea here is that we don't expect the primary care provider will manage bipolar disorder on their own. It's a bit more complex. And this is not a cookbook. It's more like a roadmap. It's more like, here's what's going to go on. Here's how it proceeds in terms of the medications. For example, here's the drill. Here's the monitoring. Here's how you do it. Here's what you watch out for. And the primary care providers I worked with found this kind of thing very helpful. This is another example of proceduralizing, taking what's inside the psychiatrist's head and just taking it out. It's not doing anybody any good in there, and spreading it out across the care of the patients. Another example is this is actually just a teaching document about the oversight of the use of antipsychotics. So lots of people get antipsychotics for lots of different reasons, some good, some not so good, but they're risky. People can put on weight, people can get into problems with diabetes. And so this can be done well, and this can be done poorly. Doing it well is, again, not complicated, a few steps. And so this is a tool I use to teach folks at ICHS. Another example of proceduralizing is policies around the use and prescription of benzodiazepines, who gets them, who doesn't. This was actually the very first thing I did, my very first day on the job as a psychiatric consultant. I went to an organization where they were having a horrible time with this. They'd basically given up on trying to manage it. And I knew this because in my detox down the road, we would see all these people who were getting, were coming in with these huge doses of Xanax. I'd say, where did you get all that Xanax? And they'd say, Doc, they'd say at North Shore, that's what they do there. And then when I was a psychiatric consultant, I was at North Shore. And the first thing I did, I get there and they say, you got to help us with this. We've lost control. So we wrote policies. It was super helpful. They could say, we have a policy. This is what we're going to do now. And then, for example, this is a teaching material and a little job aid that I wrote for ICHS. ICHS is doing a lot of MAT, and they have been engaged with some opioid treatment providers in their neighborhoods who are referring folks who are on methadone and benzos because there's the risk of fatal overdose is much higher in that situation. And so the ICHS has agreed to do the hard and very unpleasant work of tapering these folks off these benzos, often which they've taken for years and which they are not happy to be coming off. And so we worked through a procedure for this, and I trained them and helped them develop procedures for doing that. So that's an example of proceduralizing what you would get a consult to do. Okay, now I'm at the end. So if nothing else, remember this: do simple things well. This is what I'm always saying. Do simple things well. That's how you get people better. None of this is complicated. 95% of psychiatric recommendations are super simple. Make sure to reassess in 4 weeks. That's like the magic. That's like the golden words of antidepressant treatment. Make sure to reassess in 4 weeks. Get your psychiatric consultant to help you streamline. Often you can. There are things that may be take up a lot of time and space for you in sort of the mental health department. Often, if you've got a plan with your in-house mental health provider, and this can be streamlined significantly. You can save a lot of time. And the use of data makes a huge difference. Getting, following, tracking, measurement data, things like PHQ-9, makes care more efficient. More time spent on the people who need it, less time spent on the people who don't need it, getting people better, and doing less, using less joules, using less power than you would otherwise. That's one of the things. So that's one of the things that's surprising. You take on this plan to address these problems that sometimes are difficult to address in primary care, but if you do it well, you actually have less work. So that often folks don't see that coming. Okie dokie. I am now at the question part. So I think I will just go in and read off the chat for starters.
Yeah, I'm happy to read the question if you.
Yeah, go for it. Go for it, Miles.
I'm sharing your screen, so you're.
Oh yeah, I will stop sharing.
And there is the first comment is by Chinda, and it's related to stigma. Stigma may not be the only reason people do not go. There might be some concerns for psychiatric facilities refusing medications to patients due to a no-show or requiring number of consultation sessions, being fired or refused medication. Can you comment on that part? You know, treatments, refusing treatment as the person doesn't appear to appointments, and also, if you would, I'm rephrasing the question, other reasons besides stigma and besides no-show as causes for this problem of interrupted care.
Yeah, this is you are quite right. That one of the things that can happen in psychiatric facilities is that they have what they call no-show management. As a former mental health administrator, it's an awful dilemma because the access problem is terrible, and you do want to use resources you want to see folks, and when you have folks on the schedule that don't come in, then you don't see folks. And so figuring out the best way to deal with that is challenging. But certainly people do go to mental health facilities and have bad experiences. The second most common, in my experience, the second most common reason for somebody not wanting to go to the mental health center is that they had an unpleasant experience having to do, for example, with an inpatient setting or with involuntary treatment or that kind of thing, which either did not go well or they felt did not go well. So there's a lot of what you say is absolutely true. Being fired or refused meds absolutely can put that off. Another, really in my view, another reason why that's often not really a realistic way of getting the patient cared for.
A question by Gerald. The ACH across the state are forging ahead to integrate mental health and medical care. Is your message for primary care properly being taken into account, or are they planning things in their vacuum?
Thank you for your question, Gerald. I have two answers to this. I think that the integration of mental health and medical care is going reasonably well. I think that well, from the point of view of provision of mental health services in primary care, that is pretty, the kind of work that's been done in Washington, the collaborative care work, is pretty well understood by the ACH as valuable. That's a lot of what drove the kind of requirement or hope or aspiration that it would be integrated, the care would be integrated. It's been much, much less successful in the area that I've been working with, providing medical services for people with severe mental illness. It's been much more challenging to get that financially supported, we're working hard to find ways to get that important work supported, but it's been challenging. But on the other side, the question I think that you're asking is, they're familiar with this evidence, they're familiar with the usefulness of this kind of work, and so I think supportive of it.
Question by Janet. How many primary care clinics in Washington State currently have a collaborative care program fully staffed? What is the timeline for statewide rollout?
Well, initially, a number of years back, there was a rollout under UW and CHPW called the MHIP, Mental Health Integration Program, and there were programs rolled out in over 100 clinics across the state. I could not tell you exactly how many there are now. I don't think it's rare. There are a lot of clinics that do something there. We think of a collaborative care model. I didn't describe it in detail today because that's not what we were talking about, but there's a few moving parts. There's a consultant psychiatrist, there's the in-house clinician, there's the data gathering, there's the use of a registry. And so using all of those parts, which we think make it really go, it's complex, and implementation is not simple. And so a lot of people do things that are parts of that, or that are less complex than that. And so do they count? There are a lot of organizations that do what's called primary care behavioral health, which does not include a psychiatric consultant, which does not include the use of data generally. And it's more oriented towards assisting the primary care provider in getting through their day and responding in an immediate way to identify behavioral health needs, though maybe not in as much a longitudinal way. And that's widely spread out. But there's no kind of centralized body that would say, okay, we are now going to roll this out across this, in the way you'd say, we're going to roll out flu shots, for example. It's a bit more one-off. If an organization identifies this as an important thing to do, there are quite a lot of resources in Washington to get that done, but there isn't kind of a centralized process of it getting spread over the state.
So the follow-up question actually from me, with your presentations on bipolar specifically, in most clinics where they have collaborative care, it had been limited, as far as I know, to common mental health disorder like depression and anxiety. Is the plan to expand that to include bipolar, and if so?
I think that the way, as I like to tell people, I spent most of the last 4 years traveling all over the country training providers to do this kind of work, and so I've seen how this happens almost everywhere. And one of the things I have to remind people is that collaborative care is not a franchise, and it's not a religion. And so it's not like you're not allowed to do this or you're not allowed to do that. If you are working in a clinic, like the one, for example, I was working in, and you have engaged yourself as making an effort to be as useful in the care of behavioral health disorders in that place as possible, you of necessity will have to engage with people who have things that are more complex. One of the great aphorisms in psychiatry is that the simple, straightforward patient is the one that you don't know very well yet. And so even in those situations where you say, okay, we're going to limit it to this little circumscribed area, good luck with that.
Question by Katie. Considering the increasingly limited or no access to therapies in many areas, what are your thoughts about the ethics of widely screening for depression and anxiety?
Well, it's generally understood that that you shouldn't screen for something that you can't treat. So I think that, you know, I think that the widely kind of held belief that regular depression screening is appropriate is predicated on the notion that depression, for example, especially in adults, can be addressed in a primary care setting. So it's not like something you can't do anything about. So the paucity of people to refer out to, that's another question. That certainly is true, as we discussed.
Right, so you're saying therapist is one modality, but there still can be medications to treat.
Yeah, or there are, you know, for example, in the collaborative care model, it's not limited to treatment with depression by any means. It's both that kind of treatment and brief psychosocial approaches carried out by the care manager are both important and both valuable and both effective. I think our idea is that, as you say, Molly, Katie, excuse me, it's often not, you know, referral out is often not available. That's why figuring out a way to spin up something that works and that is supportable and sustainable in primary care, I think is important in the way. I don't think it's just the only way to go. I think it's a good way to go. I think it actually works better in most, not in all, but in many, many settings. I think it can be turned to this effectively.
Question by Molly: thoughts on best care for adults complaining of ADD or ADHD not previously diagnosed as children? How about geriatric patients who complain of symptoms related to that, requesting stimulants?
So you remember how I was talking about how basically, you know, a lot of this is straightforward, you know, straightforward evaluation, straightforward questions, doing simple things well, like walking through the steps. Adult ADHD is really challenging because it's not, somebody's holding their head up there. It's really challenging because you just don't have the same kind of, you can't put if someone comes in and they're depressed, you know, you can get a sense of that. People come in and they say, I'm having trouble concentrating. It's complex because it's so subjective. And so we try hard to think of ways to focus those kinds of assessments. I think that in the field that's still, you know, in the specialty field of treating adults with ADHD, they have rating scales and they have, you know, and sometimes that's helpful and sometimes it's not. I could go on. That could be another talk. The short answer is that it's challenging, and I think having some assistance with doing that, or at least a procedure to walk through would be of value, of course, because you get asked this all the time. You know, it used to be back in what the problem is, a lot of the rating scales were created back in the day when nobody knew about adult ADHD, and people would be depressed and they go, you might have ADHD too, and the patient would say, well, what's that? And so you would do but now they have these rating scales and they're all so face valid. Like, do you have trouble concentrating? Do you have some trouble finishing tasks? Do your thoughts wander? And well, they go, yes, because that's how I have ADHD. Can I have my Adderall now? So I don't know what to tell you. It's hard for me too.
Thank you. Question by Peter: could you say a few words about the finances and reimbursements for collaborative care mental health?
Yes, I can. I could say many, many words. The short version is, what we aspire to is a scenario in which there is actual, honest to God, value-based payment. And this kind of rather efficient and model, certainly efficient in terms of its use of psychiatric resources, could be applied in a, you know, globally funded practice without having to worry so much about how do you pay for the individual widgets. There are individual CPT codes and billing codes that are payable for collaborative care, and they're set up like chronic complex care codes. And so some of the team spends so many minutes in the course of a month, and it gets billed in that way. And it's wonky and it's not very straightforward. And we kind of think of it as the awkward adolescence of the funding of collaborative care. Yeah, I think it will really hit its stride when you're looking more at a globally funded kind of situation. I actually work, one of my consultation jobs is with an organization that is entirely capitated, and it works great there.
Thank you. And we have 4 more minutes. I like this conversation, so we can take a couple more questions. A question by Debbie: what are the best initial bipolar screen questions to use in primary care?
The way we usually do this, we don't start with a formal evaluation, but pretty early on we use something that's called the CIDI, which is an approach, a very valid approach to psychiatric, to bipolar diagnosis, that's originally created by the World Health Organization. And the first couple of questions are like, have you ever had a period, of lasting of more than a week or so where you found yourself being especially irritable or especially agitated? You can have there's a short list of kind of STEM questions, and if they don't bite on those, then they probably don't have bipolar disorder. But that's the kind of framework we usually use from it. It's quite valid. It's amazingly valid, actually.
Kari had an observation and a question. The observation, actually, let's start with the question. Does collaborative care include therapy and counseling? The observation, interesting that psychiatry and therapy are so often separate.
Yes, you're right about that. And this is a source of grief to me in many ways, because I'm old enough to have been brought up as a psychotherapist. And I think that psychiatric education has given that short shrift in recent years. I think it's changed to some degree, and there are and have always been young psychiatrists who are interested in psychotherapy and seek out training and work in that area. But yet you see, it's not unusual to encounter psychiatric providers, including nurse practitioners, who are very medication focused, and I think that there's some, from my point of view, some impoverishment in terms of the coordination of all the kinds of things that can make a person better. And so one of the kind of core principles of collaborative care is patient-centered care. And so, for example, for something like depression, for something like anxiety, there's more than one way to skin the cat. Medication can work, psychotherapy can work, they can work better together. But often patients have a preference for one or the other. And some patients will say, don't talk to me about that mumbo jumbo therapy stuff, give me, where's my pill? And some patients who are depressed will say, stay away from me with that dangerous mind drug and listen to me. And those are both point of views. And I think that, you can imagine that someone who's getting treatment that feels and sounds the way that they think treatment should feel and sound is likely to do somewhat better. And our view is that they're equally valid, and that you should do what works. The best therapy is the one that works.
There is a comment by Lone, and I will end with that, sent privately to Simone, saying that in the FQHC, actually I'll share with everyone. Well, it might not be easy to copy and paste. Okay, here it is. Working at FQHC and participated in the SPIRIT study, pleased, not surprised with the findings. Most of the patient participated benefited from the care they received, and the group also learned a lot. Can you share, we'll end with this one, we're getting to the final minute. Any tips to primary care providers to address some of the challenges as they roll out the collaborative care model? What do you, from your experiences working with primary care doctors, what do they struggle with as they start working within that collaborative team structures, and how can they address those challenges?
I think the best thing to do, I think that often primary care providers feel, this may or not may be accurate for the folks that are attending this call. I have worked with many folks who feel like this particular bit of work that's has been foisted upon them is not really their gig, it's not really within their scope of practice, and they feel either that it's something extra that they don't, and almost everybody feels like they haven't been trained, and which is, that's I can relate to that. I think the thing to do if you find yourself in a situation like that, if you have an in-house behavioral health provider, if you have psychiatric consultant is use them. The psychiatric consultant is at your disposal. So I have a terrible time. I've been doing this for a long time. And when I do a consultation, my phone number's on it, my email's on it. I say, call me anytime. I make sure everybody has my phone number. And if someone calls me and says, I've got something in my office and I got a quick question, I'll answer that phone call. People don't believe this, but it's true. And so make it work for you. Reach out to the people who you're working with, call them, talk to them, ask them questions, let them know what it is you need help with. And that's my job. That's our job, is to help us do a better job taking care of these patients. I don't know, well, I have some ideas, but I don't necessarily know what you need from me the way you do. And so it's helpful for you to let me know so I can give it to you.
Thank you, John. At the end of the session, express our gratitude for you for joining us today. Very informative session.